tomara, né? Porque senão a gente fica meio...
Ah, não,
Oi,
sim,
tudo
daí
bem?
pode fechar a câmera. É bom que já vai testando o inglês, prof.
Meu Deus do céu, não quero testar inglês, eu já vou ter... Ai, meu Deus. Ah, por falar
Ai.
nisso, eu vou passar pro meu tablet aqui uma coisa.
Tá. Mas que experiência, né, prof, poder ter ela para tipo, dar
Uh,
sugestões e participar, vai ser muito bom.
vai ser ótimo. Eu acho que a banca tá muito legal, assim. Tá digno de uma tese mesmo, assim, para vir as contribuições e tudo, né?
Sim.
Acho que vai ser bem...
Ah, ela fez uma pergunta lá no documento que eu me preparei já para responder, mas tá gravando não, né? Só
Não,
para
tô
saber.
gravando nada.
Tá. É, que ela falou assim, prof, que quando se faz a Atkins, né, a gente não tem a pesagem, a balança,
Isso.
né? Por que que a
Eu
gente
vi.
usou que na nossa metodologia está descrito, na foto do nosso diário também tem lá, tipo, a balancinha, na foto do cardápio tem os 5 gramas de cada refeição, então, a princípio, o paciente teria que estar pesando para bater exatamente, né?
Uhum.
Então, quando a gente olhou o consumo, dá exatamente 65%. A gente está numa Atkins modificada. Só que quando tu tem a pesagem, tu teria uma classificação de uma dieta cetogênica modificada e não a Atkins modificada quando se usa a balança.
Eu nunca ouvi falar disso, tá?
Ela
A
colocou
mulher
também.
sabe.
Na verdade, até naquele gráfico que a gente usa para classificar a clássica modificada 2 para um, 3 para um, está escrito ketogenic modify diet. Então, quando tu
Uhum.
muda a clássica para outros proporcionais, isso acontece.
Ah, não, não. Eu tô falando que eu nunca ouvi falar que a pesagem fosse um critério para ser Atkins ou, entendeu?
Sim, sim. Não, mas
Eu acho
na
que
nossa
dá.
tese tá até escrito que a gente incentiva o consumo sem a necessidade de pesagem. E é o que
Sim,
está
mas
na
não tem.
referência.
Mas eu acho que o que tu pode dizer que a gente sugere que eles pesem, a gente tem que até cuidar com isso.
Uhum.
Porque por uma questão de adesão, de entendimento das porções, de olhar em
Isso,
cima, na verdade é uma estratégia de educação nutricional que a gente usa. A
isso.
gente
É isso
faz
que eu
isso em
pensei.
qualquer outra dieta também,
Uhum,
né?
uhum.
Tipo, por exemplo, a gente vai usar ou sugerir que pacientes que estão em dieta normal usem a balança para entender o que
Exato,
que é o que que significa uma colher ou, né, tantas gramas de tal coisa.
exatamente. Exato. E para que também aquele grupo que é mais controlado, que é o grupo, né, do frutas, vegetais, para que eles saibam exatamente quando forem consumir, que aquela quantidade tem que ser limitada para não afetar a cetose. Mas que
Isso.
depois de um certo tempo eles têm autonomia para, né, para
Sim, é
consumir
só
os
no
alimentos de forma
começo
mais
mesmo,
livre.
né,
Uhum.
para entender. Não é obrigatório, não é uma coisa, né? Mas o que ela quer
Uhum.
dizer, eu acho que é livre. É a questão do não ser controlado,
Isso
sabe?
que não se controla, é. Não, e ela
Isso.
tá certa. Acho que tá certo o comentário, depois a gente revê a
Sim,
hora de
sim.
escrever o
Aham.
artigo também. Prof, eu vou só ali fazer um
Hum.
xixi, pegar mais uma água
Vai, eu também daqui a
e
pouco
já
eu vou,
vou.
só vou ver se eu consigo
Tá, já volto
conferir
aqui.
meu negócio. E aí, Lê? Tudo? Oi? Tô nervosa.
Tu?
Eu tô. Mais que a Mayara, eu acho, sei lá. Mayara foi fazer um xixizinho. Deve estar voltando
Ah,
daqui a pouco.
Eu acho que eu vou conseguir assistir só a apresentação dela, que eu tenho aula.
Ai, sério? Que saco. Quem que dá aula na segunda, gente?
Eu, né?
Uma universidade pública.
É um absurdo.
Bando de vagabundo aí, tudo dando aula na segunda.
Gente que não faz nada. Mas vai dar
Ah,
tudo certo.
não. Não, vai sim. Uhum. Acho que vai ser bem legal. Acho que vai ser top. Ela já
Vai ficar
mandou
gravado,
algumas
né?
coisas pra Maira, você vem... Hã?
Vai ficar gravado, né?
Vai, vou deixar lá
No
no
YouTube, né?
YouTube. Uhum.
Daí eu
Já
vejo
tá
depois.
até tudo certo aqui.
Vai dar tudo certo, vai dar tudo certo.
É. Ó,
Oi,
tá aí
prof.
a moça.
Oi,
Tudo bem?
tudo e tu?
Meu
Eu tô
Deus,
bem.
eu acho que eu também tô.
Falei agora,
Ai, é.
Ô, Maia, eu tava dizendo pra Débora, eu dou aula agora, daqui a pouco, então eu acho que eu vou
Sim.
conseguir, pelo menos essa apresentação, acho que vai dar.
Ai, que bom.
Aí depois eu
Que
olho
pena.
no YouTube, na gravação, o resto.
Sim, sim, depois a gente faz um resumo.
Isso. Mas vai dar tudo certo, fiquem tranquilas.
Vai sim.
Vai sim. Treinamos, o inglês tá daquele jeito, mas vai dar tudo certo.
Os outros professores da banca que se virem, né? Porque vai ser em inglês, meu bem.
Meu Deus, sim, muito chique, né?
Ah, demais.
Eu tô até pensando, né? Vai que eu que vou me ferrar daí,
Ó,
vai que eles querem ser.
agora tá aparecendo o nome dela, é a Cervenka.
Tá, beleza.
Então,
Isso.
Fica aí,
Vai
Letícia,
ver.
fica aí. Ela entrou. Ela tava. Antes estava aparecendo um nome engraçado, acho que tava com outro nome. Vamos ver se dá certo de abrir os microfone. Deu. Ah,
Ah, o prof lembrar de tirar as notificações do WhatsApp se o WhatsApp estiver ligado, né? O
já
áudio.
desliguei.
Tá. E a
Do
Kátia,
computador já.
depois. A
Depois
Kátia
dá um.
ontem. Já não mandei, ela achou que ela tinha que ler alguma coisa da tese, eu falei, tu não tem que ler nada, tu só tem que participar, tipo assim, entrar na mesma sala que a gente, sabe?
Ah, ela achou que era para ler alguma
Ela achou que
coisa.
ela, não, que ela tinha que comentar alguma coisa, eu falei, não, prof, é só
A
pra te não
professora
entrar
Kátia
só no
acabou de pedir para
YouTube.
entrar. Ela acabou de pedir para entrar aqui, a professora Kátia.
Ai,
Chegou.
então tá.
Será que a gente dá um bom dia em inglês para ver se ela está nos ouvindo?
Sim. Good morning, Mackenzie.
Good morning.
Oh, good morning,
Ai,
lindíssimas.
ai, ela saiu. Ela caiu, eu acho. Ah, não, tá ali.
Não, tá aparecendo para
Tá
mim.
ali.
Bom dia, Kátia.
Olá, hello
bom dia,
people.
bom dia.
Good
Bom
morning.
dia.
Quer colocar a tua apresentação aqui, a primeira página? Não é para
Aham,
ficar.
quero.
Chegou o grande dia, hein?
Chegou, nem acredito, prof.
Nossa, eu tô mais nervosa que a Maiara.
Não, não fala isso não, prof.
Mas é que tem outra coisa, né, Maiara? Tu é minha primeira aluna de doutorado. Eu nunca defendi um
Oh!
doutorado.
Pô, mas então estreou com tudo, né, Débora?
Me
Com a
autoestima.
defesa internacional. Tá querendo pouco, né?
Exatamente.
O problema de começar assim, né, Kátia, é manter depois, né?
Agora,
Mackenzie.
Hum,
I just talked to everyone there. That's Mayara is my first doctoral student. It's my first defense. I didn't do this before.
Oh, congratulations. Well, this is the first time I've attended one of these, so that's wonderful. Thank you all for inviting me. I'm really excited. And can you hear me okay? I'm not familiar with this platform.
Yeah.
Yeah,
Yeah.
great.
I can hear you.
Thank you so much, Cervenka, for being here with us today. I know it's very early for you, but I very
Oh,
appreciate your presence.
no, thank you. And it's not early. I've been up for a long time.
Professor Deborah, do you want to maybe explain a little bit to Cervenka? I don't know if we explain now or maybe later that we
Oh,
are going to
yeah,
have.
I will talk a little bit later at the formal part, but we will start at this first moment. Mayara have 40 minutes to talk, to do her presentation. Then before we have the moment that we talk, the professors, the committee talk to Mayara. So we have this idea that the person that works more far from us is the first one to talk, just to have some order. So you start talking to Mayara. Then you have 20 minutes. Mayara have 20 minutes to answer you. But if you like to make some talk, you talk and Mayara talk. This is a choice. It's not a problem. And before we have two more professors to talk with Mayara. And then we have this moment when we go to another room to make some comments, do the grade, the evaluation, and then we come back here to talk to Mayara and finish this work. I don't know if you understand me.
Oh, absolutely. Yes. Yes.
Mackenzie, great to see you here. How are you?
Hi, Katya. It's great to see you too.
I just want to check if you received my email last week. I answered to your email right away, but I didn't get any response from you.
Yes, yeah, I was catching up over the weekend, and I
Okay.
forwarded it to the ILAE. So I was yeah, thank you, because I realized
Okay.
that there were a couple of names that weren't on the website or updated, so I sent them a few. So thank you so much.
Oh, I'm the one who should thank you. Thank you so much.
I have no idea how often people use that resource, but I figured if they do, I want it to be updated.
Yeah, thank you so much.
I think Professor Patricia also join us.
Yes, hello. Good morning.
Hi, Professor. Good morning.
I don't know. Really cold
you.
here in my room.
Yeah. Thank you, Professor, for being here today with us.
My pleasure.
Hi, Yara.
Bom dia. Good morning.
Good morning, Professor Yara. Thank you for being here today.
I like to say that we have the transmission from our YouTube, but this is a private one. Just people who have the link will be accessed, so it's not a public one. Okay, just to don't have I need to protect this room to other people to come, so we put that in the YouTube to family and friends and other persons. We just have some more minutes. Just wait to start.
Just a minute.
Consegue compartilhar a tua tela. Isso, obrigada, Maia.
Is everything okay with my slides? Professor Deborah, can you hear me?
Yeah. It's
Okay,
Oh,
just
now
to
you close? You close.
no, yeah,
Because
just to
yeah.
yeah, because I just want to know if you are hearing me well and if the slide is okay.
Yeah.
Okay, thank you.
If you like, when Mayara starts to talk and do her presentation, we can close our cameras and we stay more private, and then before we come back.
So just to inform, when I am in the presentation, I cannot see you. So if any problem happen, anyone can give me some advice from the phone so I can know if the presentation stops or if my voice also stop. You can just let me know.
I will be that person. Okay, Mayara.
Yeah.
So for me, it's 8:30. We can start, everyone. I will start the transmission. Oh, I think that it's okay. Yeah. So welcome all to the doctoral thesis defense of Maira Cristina de Lima. I thank you everyone for being here today, especially the members of the committee. According to the regulations of the graduate program in nutrition, the thesis defense proceeds consists of two stages. The first involves the oral presentation of the conducted study, and the second involves the defending against the questions posed by the examining committee members. At this initial stage, I will invite Mayara, who has 40 minutes to present her work.
Thank you, Professor Deborah. Can I start? Thank you all the members from committee for being here and join us today in my presentation of the thesis. And I also thank you, my advisor and co-advisor, Deborah Vensky and Julia Dubois, for orienting me during these past 4 years. So my thesis is intitulated The Effect of the Ketogenic Diet in Adults with Pharmacoresistant Epilepsy on Serum Levels of BDNF, NSE, and Cognition, a quasi-experimental study. So to start, I would like to bring the relevance of studying epilepsy, principally here in Brazil. So when we look to the data of the world, we have 5 million people who are diagnosed with epilepsy each year. And when we look to the data from income for high-income countries, we see a data from 49 per 100,000 people who are diagnosed with epilepsy each year. And when we look to in low and middle and low country, this number can increase and reach up to 139 per 100,000 people. So near to this data, 80% of people who live with epilepsy are in low and in middle income country. That is the case that we look here in Brazil. So in this chronic neurological disorder that is considered a repeat epileptic seizure, when we look to the concept of epilepsy, we know that from this population, who are 1 to 2% of the global population, 30% of them will remain pharmacoresistant epilepsy, which that means that they don't respond to pharmacological treatments. In some cases also, they are not candidate for surgery also. So looking to this population is important to highlight that it's not only about the seizure itself and what happens in the brain of this patient, but it's also related to the impact in the quality of life of these individuals. So we also observe the impairment in cognitive skills, the loss of employment opportunities, also the loss of independence, and affect also their marriage and their relationships with the others. So what the literature showed to us is that the sudden onset of seizure and also the side effects of seizure medication, this all affect the life of these patients. And also the concern about psychosocial functioning and also the capacity of learning is also affected. And we cannot forget that this patient also have increased risk of death that in the concept of epilepsy, we call the SUDEP. So look into this other field that patient who presents epilepsy might be impairment is the field of the cognition. So the data from Hammer 2021 showed to us that approximately 30 to 40% of adults, they live with cognitive impairment. It's a very high risk from impact cognitive. And we also see cognitive decline in memory, executive function, and also attention. Other areas from cognitive impairment that we can say they also may live with is decreasing learning ability, and also they can present intellectual disability, fine motor skills difficulties, and also working memory deficits. Verbal memory deficit is also seen in this patient, and executive dysfunction and behavior problems, it also impairing cognitive abilities. So to better understand how was the main point of what the data have showed to us until 2021 and 2022, we run a review intitulated Ketogenic Diet, Epilepsy and Cognition. So what we know so far. And we have found so many data from this review. And so many authors bring in a data that we already have looking for. That is, the keto is effective in reducing seizures. And we have so many variables to assess cognition. But the main point of the review that we keep asking ourselves was what is behind cognitive improvement? Would be any biomarkers or neurotrophin that may be involved in the epilepsy context association to cognition? And so we look to the literature to better understand what was the link between cognition, epilepsy, and probably ketogenic diet. So we need to bring the concept that we find about neuroplasticity. So we know that it's a very intense and deep concept, but involves the change in the efficacy of existing synaptic contacts, and as well as the formation of new synaptic contacts and their own elimination by the structure of the brain, so leading to a large-scale change in dendritic and axonal arborization. So the neurotrophin that is very widely studied in the brain and in the concept of neuroplasticity is the BDNF, which is the most widely distributed neurotrophin in the central nervous system. Also is known to be strongly involved in the expression of consolidation and synaptic plasticity that we call the long-term potentiation, the long-term depreciation also. And the BDNF action occurs through its binding by this own receptor that we call TRKB. So when this receptor is active, we can promote a whole cascade of intracellular signaling, bringing also this new change in the dendritic area and axonal arborization also. So when we look to the field of epilepsy and the neural excitability and also plasticity, we have some data showing that we can activate neuronal excitability by glucose and EGF-1 levels. So also there is some data in the literature showing to us that BDNF and TRKB also play a role in neuronal excitability. And we have this concept bring to by us from Shaw 2015, where he calls this term for aberrant plasticity, that we also can observe in patients with epilepsy and other areas of psychiatry. So the epileptiform activity would be involved by some authors that can explain that we have the hypersynchronous recruitment for seminal neurons and also interneurons, provoking a state of excess of neural excitability, so what we would say aberrant plasticity. In this context, we may see activation more than the physiology from TRKB, a receptor, and also this excess of excitability in the brain and the lowest level of the control of the GABAergic system also could implicate in the neuron of death. So in the context of epileptogenesis, we might see this overexpression of BDNF leading to increase in excitability and also in the neuronal cell death. So BDNF in the context of epilepsy, we have very new data, but also old data showing to us that we could see in vitro and in vivo models, also showing that the BDNF could increase the neuronal excitability, suggesting that BDNF could facilitate the states of epileptogenesis. And also higher level of BDNF found in epileptic patients had a positive correlation between BDNF and its own receptor. Another interesting data showing to us that BDNF and the TRKB were higher in the cerebrospinal fluid, also in patients with temporal lobe epilepsy, than in peripheral blood. And the pharmacoresistant epilepsy also show higher levels of BDNF, which is our focus from study of this work that we are presenting today. And when we look to the next mechanism that we can say that might happen in patients also with epilepsy is this biomarker that can show to us a neuronal damage. So when the neuronal damage happen, or also when we have the neuronal death. So we can say that what the literature has shown to us is that we have increased concentration of serum NSE in cerebral infection in traumatic brain, but we also have data showing that in status epilepticus, we can also observe a higher levels in the blood of NSE. So looking near to this data that we observe the NSE is higher in patients with epilepsy. It's important to highlight that this is a protein that constitutes 0.4% until 2.2% of the total soluble protein in the brain, depending on the region, and is one of the most widely studied and used biochemical marker to assess neuronal damage, and also can be measured both in the serum and in the central nervous system. So interesting data from Tikhonova from 2024 showing to us that serum NSA levels increase during the first 48 hours after a seizure, and also could be correlate with the outcome and also from the duration of what the seizure happened. So in this context, we need to understand that patients who keep pharmacoresistant epilepsy, they have this gap between what is about the treatment and the anti-seizure medication and what they could also apply as a non-pharmacological treatment. So we observe that ketogenic diet is a diet that is available. It's a viable alternative for implementation and also to adherence. So we know that is a diet that can induce to side effects, but all the work published until the moment, they show that we can manage all the side effects. And also we can observe in our review that the keto can improve the frequency and the intensity of the seizures. And we have so many different mechanisms to try to explain how the diet can affect the brain. But the main one that was the most studied was the action of the ketone bodies that could affect the anticonvulsivant effect by 3 hypotheses that we have known so far. There are the control for ionic channels, the glutamatergic control, and also the stimulus from GABA production by the induction of glutamine and GABA also. And so look into all this field that we have studied so far, how the patient who presents epilepsy might be affected in so many areas. And one of them is the cognition that can directly affect the employment, the quality of life, the relationships, and their lives itself. We ask ourselves, how does the other treatment that were non-pharmacological one could affect the cognition and the neurotrophic factors? So we did the starting question, how does the ketogenic diet influence plasticity factors and cognition in patients with pharmacoresistant epilepsy? So we set our main goals to evaluate the effects of nutritional intervention with a modified Atkins diet in the adults, and also to observe how it was about the cognitive parameters and the effectiveness of reducing seizures. And we have the set of specific ones that was looking to the neurotrophins from BDNF and also NSC concentrations in each time that we would measure every part of the study. And also to apply the trail-making test, COLI-31, and the scale of anxiety and depression. So we have this quasi-experimental study with intervention using the ketogenic diet with patients with a well-established diagnosis from pharmacoresistant epilepsy, according to the compatibility from clinical history, seizure semiology, and also EEG and brain MRI. All these centers send to our nutritional ketogenic diet clinic for seeing the patients and be accompanied by a multidisciplinary team. Our sample determination was with adults only, so all the patients above 18 years, both sex, and our sample size were determined by temporal saturation from June 2022 to December 2023. Here we have our research stage, where we begin in the first consultation with a multidisciplinary team, where we did an anamnesis, and also we talk with the patient how the diet works, if they were prepared, if they have any caregiver that could take care of the diet to help the patient to follow, or even if the own patient could administrate the diet for a minimum of 3 months. So in visit 2, the time 0, visit 3, the first month, visit 4, the 3 months, and the visit 5, 6 months, we repeat the measure from the blood samples, the thrombometric factors, the seizure diary, and also the blood collection for the posterior analysis of BDNF and also NSC. And to measure the questionnaires from the cognition, quality of life, and anxiety, we did in the appliance in the pre-diet moment in 3 months, here in the visit 4, and we did also in the visit 5. So to determination of the number of the seizure, we need to be aware about the effectiveness of the diet treatment. So the patient or the caregiver were invited to put it down every day in the end of the day or every single moment that a seizure happened. So we could try to measure the effective treatment that was considered if the seizure reduced equal or more than 50% of epileptic seizure compared to the baseline moment, and the seizure-free patient was considering a non-epileptic seizures. So our diet intervention was the MED. There is a consideration from the classic one, is more palatable and is also easier to the patient follow and to have the adherence. So we did this information that was educational information to the patient, where foods that had the green label were free or very low in carbs, so they can eat a higher amount of it. And at the same time, the foods with the yellow part was food with moderate carbohydrate content, and so they require some calcium. And foods with carbohydrate content also, and consume so small portion because they would pass the 5 grams each meal. So we did that with the scale induction in the first moment to help the patient to have notion about the diet. And because they also can confound the high protein diets here is very common for us in Brazil. So we did this first point to better instruct our patients. So when we look to the analysis from neurotrophin and brain damage, we utilize the enzyme link immunoabsorbent assay that is considered the ELISA method, and we follow all the manufacturer's recommendations technique. So we did all the following steps from BDNF preparation and incubation of the 96 plate well-captured antibodies, where sequentially washes were made in addition of sample incubation for future analysis from the calorimetry detection. So all the results were ensured by testing all in duplicate data. And NSCSA process was very similar one, but the technology from Abicam was only a single step by connection antibody analyte complex for posterior calorimetric detection. So it's a more simplified process where it takes around 90 minutes, and the result also measured by absorbance. So we also did the food consumption with a recordatory 24 hours, and we measured the total intake, carbohydrate, protein, and all the poly and monosaturated fat acids. And to assess the consumption of our patient, we looked to the My Keto Diary that we could ask from the patient also to take notes about their foods, but also to take notes about the ketosis. So we also considered adherence from the diet, not only the record 24 hours, and then we also measure the ketone bodies. So in the literature, we have the data that suggests that adults could be at the stage of 0.5 to 1.5, but this is just an average. So if they were higher, it was greater, but we consider that adults may not achieve the same levels of ketones from the children's. So from anthropometric assessment, we did the waist, the height, the waist circumference, arm circumference, and also body fat mass and fat-free mass from the DEX analysis, and another one with stadiometer and the electronic scale. So for the executive function of cognition, we use the trail making test, where we have separately parts that are given to the patient in the consult. So we have the part A, where the individual must draw a lines connecting consecutively numbers from circles. So here we connect 1 to 25 and start 1 to 2, 2 to 3, and then so on. And in part B, the individual must connect numbers to letter 1 to A, 2 to B, 3 to C, and then so on. And we consider the score about the total time in seconds that the patient complete the test. And the comparison of the test is by himself at the time 0 and the score over the time. In the part A, we may achieve alertness, concentration, information process capacity, motor speed and agility, and visual motor coordination. And in part B, we have the test the ability to switch between different stimulus. So the individual has received an instruction that he may try to complete the test as quickly as possible. And also the score with the total time in seconds, sorry. And to assess quality of life, we utilized Quali 31, that is a shorter version for Quali 89, where we have 7 domains: overall quality of life, emotional well-being, cognitive function, medication effects, and social function, and energy and fatigue. The average is not the sum, but is the product of the score scale through our empirically derived coefficients. And we also utilize the heads. There is the scale of anxiety and depression to achieve 7 domains from anxiety and 7 investigations from depression. So we did a statistical analysis with the SPSS 29 version, where we run the data normality, and we made a generalized estimate equation from all our variables. So anthropometric factors, heads, trail making test, and NSA, BDNC. We utilize generalized estimate equation because it allows us for a smaller sample size and missing data also, but still, in this case, we can demonstrate the same size effect with a power of 80%. And we utilize the gamma distribution logarithmic function with post-Hostek von Ferroni and assume statistical significance P above 0.05. Here are ethical procedures for following the research. And so I will bring now the results and the discussion. Just for beginning, the results in the second article, but just to take in an overview about what we have found. So we have already showed that keto was effective on reducing seizures. And we bring that we have so many different ways to assess cognition. Self-report were a very utilized one, also COG-89. And we have some specific varies that Berry and also FEPSI, auditory, and others. And some highlights that I would like to bring was the direct study from Howell 2019 that showed that cognition was affected by the amount of carbohydrate in relation to MED15 and to MED50. And we also have another interesting results showing that probably the reduction of the seizure was the main effect of influencing on cognition. So the main findings of our article was studies included this review. All of them suggest that keto was possible to influence in cognition improvement. Some authors reported improvement will be appeared by dependence and by keto affect the seizures, and the effectiveness of the keto could also be influenced by the amount of carbohydrate intake. As I mentioned in the start presentation, we have so many variabilities to assess cognition, and it was not possible to determine exactly the impact of keto on cognition. So we also did not see any neurotrophins or biomarkers associated. So that's the reason we run the first article about our results that I will present now. So we have started the pre-diet moment with 11 patients that were recruited. We only have 2 patients that did not give the sequence because they report financial difficulties to follow the diet and other difficulty to achieve a carbohydrate restricted diet. We follow with 9 patients until the week 12, and then we keep to the final analysis 7 patients. So when we look to the clinical demography characteristic, we find 9 patients in the beginning. The mean age were 40 years and the educational level around 11 years. We have 5 women and 4 men in our sample, and so many variable cause of epilepsy. And we have separately patients with etiology of the seizures with 8 and generalized one with 1. And we have different stages of amount of the anti-seizure medications. They are described also in the table. So the main finding when we look to the application of the ketogenic diet is to observe if the seizures are reducing over the time. So we could observe a significant reduction in the bilateral seizures, or we can say also generalized seizures, where we start with 7 seizures per month, and we ended in the week 4 in 4.13. So it was statistically significant when we compare to the pre-diet moment, and also keeping with the reduction over the 24 weeks, but not significant statistically. And when we look to focal seizure, even though we see different results over the time, we cannot say it was statistic. But when we look each patient in the table 2 that we let in our thesis, you can look each patient and their own reduction over the time. So trying to look better to the main outcome of our results, we have the presentation from the trail making test, where we see a different statistical difference over the time with the RP in the end 0.010. And we have the pre-diet moment start with 63 seconds for finish the trail making test A. Until the week 12, the patient had almost reduction for 20 seconds and was statistically different from the pre-diet moment. And then we have week 24, where we also have different when we look to the pre-diet moment. So showing to us a very interesting reduction in the time of finishing this test, where we can say that we might assess alertness, concentration also, and to change the stimulus activation from the executive function, we also saw a reduction. And in this area, from the trail making test B, we saw a reduction from the pre-diet moment to the week 24, where we have a reduction the 122 to 89 seconds to finish. And looking to the week 12, patients also observed an improvement, so 89 seconds, and then were 112 seconds in the week 12, all statistically significant from the end of the study. So from our discussion, we bring the study from Hasegawa Anaka for 2023 that applied the same test with patients with focal epilepsy. So this study included a higher sample size with 132 patients, also adults, where they did twice in a year the trail making test. So they applied a multiple regression analysis, showing that longer periods of active seizures were associated with poor performance in the first test of trail-making test. So they compare B to A. And also what they observed was that the number of the seizure drugs, anti-seizure medication, were associated with poor performance on the first trail-making test. So very interesting data. In our study, we could not give any correlation about what we observe here in the numbers of the seizure because we have so little sample size. But it's interesting to realize also that our patient had a decrease in the total of generalized seizures, and we also observe improvement in the trail-making test scores in the end. So when we look deeper to the BDNF and the NSA, we observe interesting reduction in the BDNF level. So 1,089 picogram per milliliter until 2,471 picogram per milliliter. So it was statistically different from the week 12 and week 24 to the pre-diet moment. And also NSE showing a reduction, or we can say reduction in this biomarker as showing as a reduction in the neuronal damage. So looking to 10 until 1 in the end of the study, picogram muscle per milliliter. And the statistical difference was shown after the diet complete 24 weeks, but also when we compare to the week 4, 1 month of the diet also. So it's interesting to highlight that BDNF, as we mentioned, it might be associated to the aberrant plasticity, and looking to the decrease of the seizure and then looking to the BDNF, we might see this behavior after we look for a reduction of the seizure and also an improvement in the cognition trail-making test. So we have some interesting data that we bring also to our discussion, as Alvin 2021 also observed that patients with epilepsy had higher levels of BDNF when we compare to the control group. And a study from Shane also looked to BDNF levels were higher in patients who did not respond to anti-seizure medication. And the study that I bring in the beginning of the presentation from 2015 also suggests that is based the increase in BDNF, the relationship between epileptogenic characteristics and epileptogenesis. And this interesting review from UGA 2018 also show interesting data that BDNF is also higher in patients with epilepsy and also appears to be correlating to the severity of the disease, also in adults, but also in children. And NSC levels over the time showing the reduction. We bring to the discussion the most recent one about honey in 2022 observed the higher level of NSC was associated with a higher risk of epileptic seizures. Also in this study showing that more than 70% of the patients with NSC were above 17 nanogram per milliliter, and 80% of the patients from who NSC increased, more than 15% between two measures will be experiencing a seizure within the next 24 hours. So as a biomarker that could predict seizures in electroencephalography. So these studies highlight the potential of NSC as a biomarker also, and is interested in assessing the risk of having epilepsy. Another study from Zhang that made association between NSA and another assessment for cognition, so from Montreal Cognitive Assessment, NSA rates in patients that present a higher dysfunction, cognitive, were also higher. So maybe there is this link between NSE level and not improvement in the score of cognitive function. So we have also observed COLI 31 improvement from the pre-diet moment to week 12, a very interesting increase, and then stabilization to week 24. And also we have the first moment where we also look for the decrease of the seizure, was the same moment where we saw improvement in the anxiety and depression score. So interesting data from our study showing also that keto may improve quality of life and also may improve anxiety and depression. We cannot say causality, any other suggestion, but it's important to know that in our current study, the symptoms of depression and anxiety decrease after 12 weeks with the med, and this improvement may also be directly associated with the improvement in the quality of life, but also in the seizure reduction. Here we demonstrate the results from macronutrient intake. So over the 6 months of the med, we have more carbohydrate in the beginning, but we could achieve in the week 4, 5, week 12, and 24 a very interesting amount of carbs, showing adherence to our diet, so less than 5%. And here the ketosis levels increasing in the metabolic stage of the first 4 weeks to 0.9 and stabilizing 0.5 and 0.49. Here also we show the change in the weight, body metric index, and the body composition. So as we have higher levels of ketosis in the week 4, we also seen amount of fat oxidation the first moment, but then we will stabilize from the next month. In the first month, we also see variables in the circumference from abdominal and waist also, but then stabilizing in the end of the study. And lean mass not showing variance, and fatty mass showing a variance from the week, not showing, different, but some patients, they have some difference between the fat mass weight. So to resume our data, when we look to the state of epilepsy, we can say that we have some difference between the neurophysiology of an individual that don't present epilepsy from BDNF and NSA. And this measure might be associated to aberrant plasticity and increase in markers in neuronal death and also affect cognitive field. And when we apply ketogenic diet, we observe a reduction in these markers, and we also observe an improvement in quality of life, improvement in anxiety and depression, and improvement in cognitive functions. I would like to bring some limitation from our works that is known by all the researchers. So we have some loss of data during the physical absence of some time of our visits. So this reduced the total of the number of analyses. We also have variation in our sample volume, so leading to some markers were not being measured all the time. We have also non-probabilistic sample size that not permit to us that we can extrapolate our results to other fields, and a simple size limitation that is also cited in the thesis. So our conclusions from our study that our study analyzed important markers in neuroplasticity and death with cognitive scales in adults with pharmacoresistant epilepsy, demonstrating significant improvement in executive function tests and in patients with pharmacoresistant epilepsy after following 24 weeks of the modified Atkins diet. In addition of improvement epileptic seizures, we also observed the patient had better score in quality of life, anxiety, and depression. And our work also suggests that NSE in BDNF concentration may be association to the reduction of the epileptic seizures after the treatment with the med, and both may be related to the improvement in the cognition factors. Our theoretical contributions about our thesis were the review study that reported the originality of the team, thesis results presented in the article form that could be provide new insights from what keto may affect cognition, on how keto may affect cognition, contributed data from Brazilian study, SCARE in both national and international literature, and prioritize publication in international journals to give visibility to nation studies also. And the practical implication highlight the importance of the first ketogenic outpatient clinic for adults in Brazil, and the clinic span shows its major achievement in potential serving as important reference from other centers near to Florianopolis and Santa Catarina. We also developed the ketogenic diet, coordinated by Professor Cachelin and Julia Dubois. This manual can serve as a tool and reference for all the centers and was inspired by the international work from the researcher Mackenzie Cervenka and Dr. Eric Kossoff. Also, we have international presentations to bring also partnerships and formalize partnerships for multidisciplinary collaboration. So for future directions, we really would like to see more studies looking for keto and cognition, maybe some randomized control clinical trials with large sample size. And also, if possible, that we could not make in this work was to look for according by improvement in cognition, by type of epilepsy, and also by etiology would be so interesting to look for. And I would like to finish my presentation because I don't have so many time. About conclusion of educational journey, I learned so many things in these past 4 years as being more critical to analyze what I read and what I teach to the others, also my patient, having autonomy to develop discussions, have critical stance in academic activity. Also was a very honor to be a part of the nutritional translator neuroscience study coordinated by all these professors that are very admired. And I have so many gratitude for Deborah Vensky, my advisor, and for Julia Dupois, my advisor, which inspired me to have more love for neuroscience and to give me back the hope that nutrition can make the difference in the life of our patient. I also so gratitude for Professor Cachelin that make all this project be possible as a medicine and inspire all of us. And also Professor Leticia Ribeiro, that if it wasn't for her, maybe I wouldn't get the master in the first place. So I also would like to bring some extra activity from the doctorship, where my participation in LILASI 2023 in São Paulo, where we have so many international discussion, a group study, and we also have the pleasure to receive the best work from LASI, where we did a theoretical job, but we try to understand if the green and the blue space might affect the appearance of epilepsy in low-income country. I also had the pleasure to present our work in the 8th Global Symposium from Ketogenic Diet, where I have the pleasure to meet in person Mackenzie, and also to ask her to come to Brazil and have this beautiful lecture about the use of the ketogenic diet in another medical also condition. We also did some media information to amplify our divulgation of the ketogenic ambulatory. And here also we did a little capacitation to a dietitian who wants to start the project in the north of Brazil. We also receive a premium from Cesare Lombroso in the 40 Congress of Epilepsy. All our team, me, Fernando, Rosa, Guilherme, all our team, Raquel, Katia, Professor Julia, Deborah. And we also contribute to the manual that I already mentioned before. So here is us with Dr. Fernando, who really helped me a lot during the Dr. Raquel, I think, is here also today. And here I have the high levels from ketosis, but after the research already from our patient Patricia. And here all of our team that I'm very grateful to be part of the project. So to finish, I would like to bring a phrase from William Couto. In the end, we realize that the destination doesn't matter. What truly matters is the journey and the people who accompany you. So thank you very much for your time. And I'm open to look for what we can learn together now. Thank you so much.
Thank you. Thank you, Maira, for the presentation. We have 41 minutes, but it's okay. It's not a problem. So now we start the second part of the work. And in this second stage, we will proceed to examination of the work by the committee. So I can say that each member will have 20 minutes to speak, and Maira will have 20 minutes to respond. Alternatively, the time may be used in the form of a dialogue where questions and answers are immediately responded by the student. For the sake of order, we will begin with the member of the committee who is external to the nutrition graduate program at UFSC. And now we will invite Dr. Mackenzie Cervenka to lead her examination. I will talk a little bit about Mackenzie. Is the director of the Adult Epilepsy Diet Center and a professor of neurology at Johns Hopkins Hospital. She's specialized in the diagnosis and treatment of patients with seizures and epilepsy, including surgical treatments and dietary therapies. She serves as an attending physician in the Epilepsy Monitoring Unit. Her specified interests include evaluations for seizure surgery, continuous electroencephalography in the intensive care unit, epilepsy in women, including considerations during pregnancy, and dietary therapies for adults with epilepsy. Dr. Cervenka's research focuses on the efficacy of ketogenic diet in the treatment of adults with epilepsy. Thank you very much, Cervenka, to stay here with us. So now we have the words.
Excellent. Well, thank you so much. Can you all hear me again? Okay,
Yeah.
fantastic. Well, it's nice to meet everyone here, and I just wanted to first congratulate Maira and also Deborah on this wonderful project that you all have worked on. This is just quite an enormous amount of effort, and I think some of the highlights in terms of just reviewing the work that you've done, looking specifically at all of these different variables, very selectively with cognition, mood, seizure frequency, and these serum ketone markers is highly unusual for our field, because usually people focus just on the seizures and really don't try to tackle the larger question of how this impacts the quality of life of the participants, and then looking also at the mechanisms simultaneously and thinking about how the diet really is potentially impacting neuronal plasticity. So I think that the neuronoplasticity piece is really an innovative part of this, and trying to combine all of these concepts together to understand better how the diet works. This is just a tremendous amount of work, and the fact that you were able to continue the diet for 24 weeks and 7 out of 9 of your participants, I still am in awe of that. In our field in general, usually the adherence rate is about 50%, or even retention rate, not even adherence. Retention rate in a study over 6 months is usually 50% or less. So that's really remarkable as well. And then the other piece that is notable from looking at the slide about what the macronutrients were at the pre-diet point in time, it is apparent that the participants that were trained, since they were trained 4 weeks prior to the diet, that by the time they reached that pre-adherence moment, pre-diet moment, they were already experimenting with higher fat diets at that point. And so the fact that you were able to show all of these statistically significant findings in this population that really, if you compared it to what we would say the American diet, where you're 50% carbohydrates coming into the study, I think you would even see more robust findings in that case. So the fact that all of this, those were all the findings, I think that's absolutely tremendous. If it's okay, I'd rather do a dialogue for our portion.
Yeah, for sure.
Okay, so I'd love to hear a little bit more about, you had mentioned in your presentation that you had 9 participants that completed the study, or that went through the study. There was 1 participant, and I realize we can't say too much about that individual, but that had generalized epilepsy, and then 8 that had focal epilepsy. And then I know that the seizures themselves were differentiated, and there were some reports about what we would call bilateral seizures, and the reduction in that seizure frequency. And so that was one clarification point that I had, or question for you. when we're saying bilateral seizures, are we incorporating the focal to bilateral seizures and the generalized bilateral seizures in that statistic?
Yeah, we are seeing patients who have focal seizure and then they develop the bilateral seizure as generalized one, but they were not in the etiology generalized. So
Okay.
I think that's the main question, right?
Yes, yes. I just wanted to differentiate because when we just say bilateral, we're not sure if that's someone who has a generalized epilepsy and might have maybe had fewer absence seizures versus someone with generalized epilepsy who has generalized tonic-clonic seizures and someone who has focal epilepsy that goes on to have generalized tonic-clonic seizures.
Perfect. Is the ones who have focal epilepsy and develop to focal to generalized one to both sides. So that's what we call bilateral seizures in our study.
Okay, perfect. Thank you.
If I can be more clear, if it can be more clearly, and it can suggest me to change the way how we wrote, I also open to suggestion. If I give the ambiguous comprehension, there would be a more correct way to describe.
So in, I guess, the latest kind of ILAE description and criteria, if you're only talking about focal onset, you would say focal to bilateral tonic-clonic rather than saying bilateral, because I think just that term bilateral is what is less clear.
Perfect. We can make that change.
Great. Excellent. And then the next question that I had, I'm sorry, I was taking notes while while I was reviewing the article and while you were giving your presentation, which was fabulous. There was, you presented, and actually in the background, you mentioned that the neuronal specific enolase levels can be elevated up to 48 hours after an individual seizure. Were you recording or keeping track of the time from the last seizure until your sample collection?
Yeah, in the study, they try to do exactly 24 hours after the collection. So they wait the 24 hour to collect the number of NSE. I think it was the Giorgio or Correlite, right? The study where he mentioned about the NSE levels. So he wait 24 hours to achieve the measure of NSE.
And actually this is, oh, sorry about that. There was a little bit of a delay. And then this is just an educational point for me. The BDNF levels, do those vary as quickly, or are those pretty stable?
No, they can vary a lot. As for example, if you do an exercise or if you change the time of your sleep, you can give a very different oscillation between almost 50% increase, or in state of stress, we can have a decrease 20%. So we have many variables that can affect actually BDNF. And I think it's it's a limitation that we also have because in our study, I did not bring that to the discussion, but we have some patients that were more active than the others that did exercise actually. So knowing that we have this parameter, we know that it can oscillate, and also how long we were from the last seizure they also had. So all this can affect BDNF levels. We are aware about it.
Okay. And you mentioned sleep. I mean, I know that was outside of the scope of the study, but there certainly there is some literature saying that that the diet can help with sleep quality and duration. So that might be another indirect mechanism if it also tends to impact BDNF levels in addition to the improvement in seizures. So that's really interesting. I wanted to go to ask about the meal plan itself. We saw that there were 5 grams of carbohydrates in 3 meals and a snack was kind of a sample meal plan for participant who might want to only eat 2 meals a day and doesn't want a snack, how would you alter that distribution
Yeah.
in that case, or were they required to have 3 meals and a snack?
Yeah, no, great question, because I remember about your lecture and I was thinking about that. So actually, when we try to teach the patient about the diet here in Brazil, we have this mix or a little bit of confusion because they really understand that keto is just a low carb diet. So where they can just not eat carbs and eat a lot of protein, and the fat, no, the fat is bad to the heart, so they just don't want to eat that. So to try to better educate our patient, we try to put this stimulus to frequent meal, but not only to control the carbs. That's not the main point, was to try to achieve the correct amount of the fat. Because we look every time they eat the eggs, but they just don't want to put the butter. They just don't want to put other fats in the meal. So to try to better take this initiate effort, we try to systematizar. We try to systematically divide the portion of the meal to give them a north about what they should eat in each time. What we realized, Patricia, that I showed to you the photo and the ketones levels, we in the beginning have so many difficult to achieve at the higher levels from ketosis because she just passed so many long terms without having a meal, and when she was going to try to put more fat, she get with nausea and she just couldn't try to achieve. So when we try to separate in 4 meals, the patient give back to us this feedback that was easier to try to achieve than we put a higher amount all that together, but was not prohibited if he want to separately do the meals. But what we observed was a not so high levels of ketosis if they separately did the 2 meals per day, for example.
Okay. And what time of day were you checking ketone bodies? I know you had a morning and an evening. Okay, that's what I thought I saw.
No, actually, Serenka, it's a great question because I will try to explain a little bit more. When we start our diets in 2018, we just didn't have the financial support to give the patients the ketone body measure. So during the pandemic, before the pandemic, we win a great financial support from Papesky. So we were able to give to the patients, but we could not measure every day because freestyle was not able in every pharmacy. So Professor Katia and I run all the city to find the less ketosis kit. So we need to make a very strict division for not to end the kit before the research. So we only could measure twice in a week. So we have Wednesday and in Saturday, and all in the end of the day. And then in the last 6-8 months, we could receive more amounts, and then we are asking to patients to repeat frequently. But we have this problem with the provider here in Brazil after pandemic, and so we just have very strict limitation. So we did the mean of 8 measures that we could achieve, and then this is the mean that I present in our project. I know it's not the standard gold parameter for achievement, but it was how we could assess the record 24 hours and the ketosis level also.
Well, I know you said it wasn't the standard, but in some articles, many, they're measuring urine ketones. So this is actually superior to that because these are much more accurate. So I think that's great. And along those same lines, you had mentioned in the thesis and in your presentation that the adherence was between 0.5 and 1.5 for the millimoles per liter. Did you have participants that went above 1.5? And if they did, were they considered non-adherent?
No, I'm sorry about that. I think I I think I wrote in the not correct way. Actually, we were having difficulty to understand why this patient didn't achieve a higher levels. So I was looking to the literature, and the article from Popper 2021, he showed that ketones level in adults may be in the mean of 0.5 and 1.5, but it was so great. We just get so happy when they were higher about that. So they were not considered not adherent. They were considered very adherent, actually. But after the even having higher amount of fat, we look that we have these decreased levels after 6, 8 weeks. They just could not achieve the same amount. Probably they were sometimes just tired about fat, and probably they decreased the levels of it. But was a measure that we took to try to incentivize actually the patient nearly to 0.5 was not the greatest level, but if the seizure were reduction, we just, okay, so if you are having reduction of the seizure, maybe your ketosis level, maybe this by your own individual metabolism, we cannot answer actually this question, but just to have these parameters we utilize. But if it was higher, it was just great. We keep very happy.
Okay, and I think you had mentioned the observation that for your patient population, it's very hard to get them to eat enough fat, but if they were able to reduce the carbohydrate, they may have been using more body fat to produce those ketone bodies at the beginning, and then once the diet sort of leveled off, then and they were not willing to incorporate more fat. I mean, because we always see that you know, the body mass index and weight trend down initially with the diet, that might have been part of the explanation for the finding. And then I always found it very interesting that with your QALY 31 data, that initially there was this improvement, and then it wasn't a statistically significant difference, but it looks like that improvement, I know you mentioned stabilized, but it looked like the scores kind of came back down a tiny bit, not to baseline. Do you have a hypothesis of why that might have been? Because everything else it looked like was very consistent in improvement over time.
Yeah. Actually, I think this was all about working with patients with epilepsy, bring me a new vision about what could be a life difference. Because when you have seizure and the seizure, they keep going because they are pharmacoresistant, it might improve, but sometimes patient will have the seizure. Every time the seizures start to coming back, even if the total amount was 50% less, patient give a very high importance. So I really understand it's not easy to live with this, but sometimes if the seizure get worse, patient just was like, I don't want to do the diet anymore. I don't achieve ketosis. Like my life is not good. I prefer back to eat in my normal life. Some patients just say, I think I prefer to have my boyfriend again because he just leave me because of the diet. So I think maybe these patients, they really get this emotional really instability by what the seizure invokes in their life. So I think when we look to a questionnaire, when we have the self-report, we have all this emotional state of the human being that is natural. And patients with epilepsy, I think this is very strongly effective in it affects, I think, the results when the seizure, they just worse. I don't know if this is your experience also, but I think this is what I could observe in our patients.
Yeah, I mean, the only other additional thought that I had was about having to be on the diet for that long, because most of the time when the 50% of patients come off of the diet that we see in our experience and in the literature, it is well before 6 months. And so most patients do seem to be adherent in those, you know, those first 3 months, and then it's something between the 3 and 6 month period that if you tend to be able to get them to 6 months, they remain on the diet and successful, but it's that interval in between. And so when you see the quality of life go down a tiny bit by 6 months, I always wonder what impact the diet itself is having on that. But you, I mean, do an excellent job of frequent follow-up. So if you're thinking about a randomized trial, I think that frequent follow-up will still be very important and very successful to emphasize, to, especially in that key 3 to 6 month interval. these patients need to be on the diet long term to see maximum benefit. No, I think that is absolutely terrific. I don't know. I didn't quite understand the instructions. Did we have 20 minutes total, or do we have?
No. If we finish, we finish after, before, not a problem, not a problem at all. But just a tiny mention, actually was the most difficult time, the 3 to the 4 month. We have so many patients want to giving up the diet, and all the team, all the dietitian encouraging, we get in the WhatsApp every single day. So I think this was a very differential from what we look to other patients that we see in the ambulatory, is that we really want to try to give the patient the hope that the keto can make the difference in his life. So I think as we can, okay, if you are not seeing that better, that we showing the results by numbers, maybe if you try 1 or 2 more months, and then you can see, and then they start to realize, but then if the seizure back, they get down. But I think this was the most difficult month, as you mentioned, the 3 to the 4. I think patient was just like, I don't want to do the diet anymore. So maybe if we could improve our abilities also to we try to give the recipes, we try to take all their doubts in WhatsApp, we try to keep motivating all the time. But yes, it's not an easy diet to follow. So we also understand when they want to stop the diet. But I think you bring some very interesting comment about it, why they might have seen not so a better improvement in quality of life, even if the seizure have the reduction.
And my last question was about the BDNF and neuron-specific enolase. What role do you see those in the future and kind of clinical practice in this field?
Well, when we started the research, it was the master. We were trying to achieve the results, but after pandemic, we just couldn't see. And me and Deborah, we talk a little bit about it, as we could have some biomarkers to try to better understand what are the mechanisms that the diet is playing a role, right? Because actually, if the ketones are so variable, if I can have a higher level, you can have even a higher one, and other people just don't make the difference. Maybe we can have some lights or some directions about who might respond better to the diet. Is the patient who will decrease BDNF, or also maybe as the ketone bodies, maybe we don't have nothing to do about BDNF, but if we does, probably we could have like, oh, this patient that can decrease BDNF have higher improvement in seizure, so we should try to keep them on a diet. But if they are just not so well responded, what other mechanism might be involved? And about NSC, I think I thought very interesting about the odds of the appearance of the seizure also was brain. So not only after a seizure, but if the levels start to get higher, maybe some brain changes are already happened. And if you can have this preventability, I don't know, as the diabetic person who can measure their own glucose level, if this patient could have a previsibility, if the seizure is going to happen by some biochemical measure, I think this could be very different from their own control, right? So they already talked to us, I am feeling that the seizure is going to happen. So if they are feeling, I don't know, something is going to happen in their measure bloods, I don't know, just imagine and wondering that if this could be possible. So another thing that we have the opportunity to discuss is the etiology of the epilepsy. So I don't know, probably not every patient is going to be a good responder. So if you have something also to try to help them to know, I think this could be also bringing new insights about it.
Excellent. Oh, that's terrific. Well, thank you so much.
Thank you, Cervenka, for all your comments and for being here with us today. I appreciate it. Thank you so much.
Thank you very much. If I must say something about this little one, this little question is that when we choose these biochemical ones, we try to understand the mechanism. We try to understand what happened, and also like Mayara say, I don't know if this would be clinical sometimes. I don't know. I think we try to understand others' questions that reduction of seizures made to our patients, and with cognition, we have the BDNF. This is very important one also. And about the consumption, this is our field. We study a lot of that. So this is our I think this is the biggest contribution that we made to the study in epilepsy in ketogenic diet. I think this is very, very important, and that we have this contribution to the study. So thank you so much, Cervenka, for staying with us. Now I will pass to the other professor. 1 second, that I need to look at my. Okay, so now I will invite Professor Dr. Patrícia de Souza Brocardo to conduct her examination of the student Mayara. She's physical therapist, has a PG in neuroscience from the Federal University of Santa Catarina, with experience in various fields such as neuropharmacology and neuroplasticity. This is very important to us. She completed her postdoctoral fellowship at the University of Victoria in Canada, and also she received international recognition by winning for the Woman in Science Award in 2014. And currently she is a professor of histology and master's and doctoral advisor at the Federal University of Santa Catarina. Thank you very much, Patrícia.
Thank you, Deborah. Thank you, Mayara, for the invitation. I want to start to say that I learned a lot about diet with you, so thank you. And I want to mention, Mackenzie, you just stole my question about BDNF. I'm so happy that you are quiet about that, because I mean, I cannot say anything about the diet, but I'll see if I can, at least contribute with something in neuroplasticity. So, Mayara, I'm going to, just to make a conversation with you. So, please don't be stressed about. I'm going to ask you some questions, but then maybe I don't know the answer also. So it's okay. We can just, talk a little bit. I want to start saying that I really like your presentation. I like the work. Like I said, I learned a lot reading. I think it's incredible what you did, with all this correlation, trying to relate, also the neuronal aspect of the diet. I think this is really important. And of course, it's not easy. And then, to correlate and to have biomarkers, I think this is what we always try to have, in neuroscience. We always try to have biomarkers to measure if you're having, some success with the therapy. And it's not easy to do. Then I made some, I'm not commenting on that, but I'm going to send you the comments that I made in your manuscript, a lot about abbreviations that you that you mess a little bit about, but then I'm going to send you. Okay. So I was confused, and I'm glad that Mackenzie asked you about that focal versus bilateral seizures, because then I was really confused, and I was thinking maybe you can, explain to me a little bit what you think is the mechanism that you observe reduce in bilateral seizures, yeah, but not in the focal seizures. So with your diet, can you think about how could this mechanism be influenced by the diet? What you see in bilateral and you don't see in focal? Did you think about that? I cannot hear you, Mayara.
Microfone, Mayara.
Sorry, are you hearing me, Professor?
Yeah.
So I before I say thank you for your comments, because it really helped me to remind what we are talking here now. So yeah, we trying to discuss a little bit about the findings. So when we look to the 9 patients in the beginning, not all of the patients have the same amount of seizures in every month. So if a same patient have improvement to the pre-diet to 4 weeks and another have increased so much, as we have so little sample size, this also, I think, may be affected by the size of the sample. And when we had a focal seizure, we are saying that we have a specific area of the brain that is being affected. And when we have focal to the generalized season, we have a higher area from the brain that is having affected. So as worse, I don't know if I can say like this, but as worse as the seizure affects the brain, the results in the controlling the seizure, I think it also might affect directly the neuronal death that we can observe in NSE. And the BDNF are correlation with a higher and aberrant plasticity, as we try to better explain. So if we are having better control in the generalized, let's say that we have improved the worst way of seizure that a patient can present. And also in focal, we have this stage of area that we call is like when patient lose a little bit of the conscious. It doesn't lose the conscience. He back very rapidly to his states, and then he remind where he were, what he was talking, and what he was saying. And when we have the bilateral or generalized, patient really lose his capacity of consciously. So maybe the diet is affecting more the worst seizure of this patient, and the focal, as they are pharmacoresistant epilepsy, they will keep having them. But if the generalized one we can reduce with the diet, I think this is affecting the neurotrophins and the biomarkers more directly than the focal seizures. Don't know if I make myself clear.
Yeah, I agree. But then I want to ask you, the ELISA kit for BDNF that you use, you measure total BDNF, pro BDNF, or mature BDNF?
The total BDNF or kit,
Yeah,
it brings all of this. Yeah.
So in my opinion, you should discuss that, because we have different receptors. And then I didn't check, but you should also check in epilepsy if you have difference, because the pro-BDNF can interact with P75. That is a different cascade, a different pathway that will lead to death, and it's different from, of course, we do have increasing neurogenesis, for example, in the hippocampus after seizures, and we have, ectopic neurogenesis, and of course this can mediate, by BDNF. But then it's important to know if you're talking about, pro or mature BDNF or total BDNF, because these are different pathways that are involved. And then also, I think you need to describe better that you measure the total BDNF.
Perfect. Okay. Perfect. Very good observation. Yeah.
So this is something that can, and then, of course, I was just thinking, because like I said, I cannot really contribute with diet, but I was thinking, what do you think of how the ketogenic diet interact with other comorbidities, like if they have cardiovascular disease, because you're saying, in Brazil, people don't like to eat fat because then they correlate with that, or if they have diabetes or things like that. So again, I'm not a nutritionist, but then how can you control for that? Can this diet interact with this other disease?
Yeah, I haven't seen any diet specifically that would increase BDNF. But as Mackenzie asked about like other things like exercise, sleep, and what we have seen also that fasting might affect BDNF levels positively. So in the diet, in the ketogenic diet, we mimetize a state of fasting as we induce to ketone bodies. But actually, I haven't read any data that show that BDNF is increased by the amount of fat or the amount of carbs. I have never read anything about it.
Yeah, I was not referring to BDNF levels, but I was just thinking about the diet in general, if you control for that, if the diet can interfere with the other disease. But yeah, because you mentioned BDNF, I want to say you should control for it. And I mean, if you have the control for exercise, you should put it results in your thesis, because of course the exercise, we know that can, alter BDNF levels.
Perfect.
But what I was asking was more about, the diet per se, if it can be, a problem if you have other disease. Can you
Like
have this
cardiovascular?
diet? What is the criteria, If I have a cardiovascular problem, can I have the keto diet to control my seizures? Is that okay? How do you control for
Okay.
that?
Yeah, actually, the patients, they pass through a medication analysis where we have our team. They do electroencephalogram, and also they do some other markers in the lab. So all the team from the neurologists, they help us to do this checklist to see if the patient is able. So we have 2 patients that wanted to start the diet, but they have cardiovascular disease, and one of them have the initial of diabetes. So he was invited to go to another ambulatory first treatment of the basal disease, so they could not have other disease associated to start in our project. And then if they get better improvement in cardiovascular and others as the glucose levels, then they could start the diet. But every time patients start, they already pass through a neurologist team, and then they do this triaging, triaging and trail titration.
Yeah, can be. I understand.
Okay.
Okay. And then the other thing that when I was reading your thesis, I was thinking about, because we talk a lot about, the brain, gut and brain X. And then I was wondering if you read something, if the keto diet can modify the microbiota, if there's studies about that, and, so I didn't check, but I was curious about if there's this
Yeah.
correlation.
Yeah, very interesting the question. Actually, when I go to Deborah the first place to do the master, I say, "Oh, professor, I'd like to look to the guts and the keto." And she looked at me like, "Real? You really want to do that?" Because I have this friend that works with the genes of the microbiome, and she had, "Mayara, if you want to do, let's do it." I'm very excited. But then when Deborah talked to me, we have so many variables that can affect the gut. So even hypoxia, even the amount of carbs, everything can affect. And what I have what I have read in the literature is that the keto, the amount of fat affect the proportion of bacteroidetes and firmicutes. They are the proportion from the gut biomarker health. So it will increase a lot the proteobacterias, and also the proportion of bacteroidetes and firmicutes. Regulation ratio will decrease. So this makes more easily to have LPS translocation and provoking the change in the gut microbiome. But for other way, we have another data showing that we can have positive effects during the keto, affecting the low grade inflammation, also in the states of the brain, also in the production of energy in the brain. So I really don't get in the state of art part of how is the team now, but what I do know is that this proportion of bacteroidetes and firmicutes, they will change during the diet. And after you start to back in the proportion of the carbs, then this microbiome will back to normal also. But we did not have any biomarkers in our study that really tried to look at, because we saw that to control the microbiome, we should have strictly exactly the same diet, because even a 10% or 5% would already change everything. So we just don't look at to this field, but I think it's a field very promising, and maybe also can affect what we are studying in the blood and the change in the brain of this patient for sure.
I agree. And then in the same line, you didn't check for any cytokines or measures of inflammation in these patients, did you?
Yeah, no, we really wanted, but we haven't financial support sufficient to try to look at. But we have already sample bloods that maybe in the future Deborah can try to dig in also to look for. It would be very interesting also.
And then
We have PCR.
Yeah, in the total, yeah.
That is one of these could make some idea.
Okay. Then the other thing that you mentioned, and those I just had wrote down. Did you have BDNF levels, okay? And then you have the ketonic bodies. Did you try to do a correlation with this?
Yeah, I
Because
tried.
you mentioned that it's playing, it would be important if you can, but then I didn't see that. And I was thinking when I was reading, okay, can you correlate that?
Yeah, we discussed a lot about this, and we even to try to put in the abstract, but actually with our sample size, we cannot achieve any levels of significance. So Professor Julia and I, we have the discussion, Deborah also was part of it, and was like, if we do a correlation with 7 patients, sometimes we have 3, so I cannot do the correlation with 3 or 4 patients, unfortunately. But if we are continue the project, so if we can have a bigger amount of patients, like next to 20 maybe, then the correlation we have a big power to us to show. But at the moment we couldn't feel comfortable to show this result because they could not say anything actually in this moment.
Yeah, and I was impressed that you saw, and you also mentioned that the others had found improvement in cognition if the diet, because I just can imagine how hard it is to keep on the diet. But then if you can, show that there's not just the seizure control, but also, we have a cognition improvement that would be, at least for me, it would be something okay.
Yeah.
I'm getting better, so I will keep on the diet. But then, do you think what is beside the ketogenic bodies? What on your diet can improve this cognition? Did you think about what the components? What is going on to improve cognition?
Yeah, in 2022, when we were trying to look better to our data, we was trying to wonder if some micronutrients as B12 and D3, and hydroxy vitamin D, if they could have some influence also, because we have read that vitamin B maybe also affect the brain function, energy, and also some authors bring that is an important fact for cognition. Also, choline in the diets. Choline might be increased in the ketogenic diet by the amount of fat. Also, a micronutrient that may be playing a role on cognition. Because if you look to the consumption of the Brazilian, they eat so more carbs than protein, and in the ketogenic diet, they also increase the amount of protein. So also the type of the fat, if have some combination in the production of some neurotransmitters, so maybe something about the micronutrients or the macro, but as I mentioned also before, we tried to do correlation in levels of vitamin B and the seizure, but was not a sufficient number of patients to try to achieve that. And also the levels of PCR during the diet, they just did not increase as some authors try to show in the high-fat diet. So probably a mechanism that the keto might have these anti-inflammatory or antioxidant also effects. But I think this was what I could think about it. That may also be affecting cognition.
Yeah, I mean, again, I'm not a nutrition, but I was thinking about omega-3, 6, 9. I don't know if this can, because, for example, we saw in the past in the lab that, when we do supplementation, we can see, cognition improvement in the animals. Then, of course, not in the clinical, but I was just thinking about that. So, but, I guess I make some notes here. Yeah, I mean, I like it. Like I said, your thesis, I want to congratulate you. And then you're continuing the studies. Is that correct? You still have this patient where you're
the keto,
recruiting others?
The keto continues. And what the team is doing now is to look at this patient after they end the ketogenic diet. So we have the patient who want to continue and who just decide they won't continue anymore. We are also going to do the measure blood to understand if the positive sides of the diet after 2-3 months can also continue be happen after they stop the diet. So the ambulatory keeps on going. Yeah.
Perfect. Yeah, because I like the session that you put about the limitation of the study, and I mean, I was, making notes, and when I reach the limitations, okay,
I'm aware.
Yeah. But yeah, this is, I mean, it's hard to work in the clinical sets, and I just imagine how hard it is to keep these patients, on the diet, and so yeah. I want to congratulate you and Deborah for the courage to do this project, and thank you again.
Thank you, Professor, for your comments. I really like the questions you made and also the comments I can receive and make the corrections after the thesis. Thank you so much.
Thank you very much, Patricia. I like to say some things that it might curious also too, but when you talk about pro-BDNF, Mature 1, and Total 1, if they have the correlation of the peripheral one with the brain one. Because with the Total 1, we have the reference that say that we have this 70% of correlation. Like we have peripherally, you have, but I don't know if you have this data with Pro1 or Mature 1. So we have to see. I see some work in obesity with Pro1 and Total 1. There is a very good idea, and I think we have to think about to measure these different kinds. Just start this conversation, maybe. And
and this possible with at least if animals we can do in tissue. You need to acidify and then you have you can extract it, so we have the total and the mature, and then of course the difference would be the pro BDNF. So we can talk about later,
Yeah, a little bit. And I like to say two things about the crisis, that we have these focal ones and generalized ones. So when you have the focal one, sometimes it's more subtle. I don't know if one's one cries or no, so it's difficult to measure, to say, oh, I have one and put this number there. So the other ones is, I have a crisis. So it's more, and the diet have, like Maira say, is more effective. When the worst is, the better the diets do, I think so. And just kind of that, I think about the bias of our patients that we choose for the the research, because we people need to read or maybe have some cognitions that do the test. So these people, I think they have more BDNF, better results at BDNF, because we know that epilepsy, they have more high BDNF. But they do, including physical activity. So this is a different. We didn't talk about to measure physical activity. Now we talk about this. So maybe we need to use some instrument to say how level of physical activity they do. This is, we talk about this in our group. Maybe it's an important measure to do to sleep we do, but activity no. And this is, I think, is a BIA. We need to think about it and read about it. And also, you talk about correlation of BDNF and ketosis. Maybe we need to choose a different way to write a work. It's not a quasi-experimental one. Maybe we need to talk about one by one. It's like many cases. So we can see of all patients, the ketones, the BDNF, the ENS1. So we can talk a little bit about this correlation. It's not a correlation, but what is happened if we took a look at one by one patient and not... So we can use also these evaluations, of course, GU1, but maybe we have more work, more something to talk about it, if you know, one by one.
I agree. Just put a table.
Yeah.
Like a table that you can see, you know.
We made a very good work with Rosa that finished her master with consumption. So we made this case by case consumption and ketosis and proteins and carbohydrates and maybe other kinds of lipids. And we take this look. I think it will be a better way. Maybe sometime when we have 21, 22 patients, we can talk a little more. So thank you very much for your contribution to our work. This look is very important to us. Out of nutritionist one, and it's very important. So now I will invite Professor Dr. Yara Franco Moreno to conduct her examination of the student Maira. So she's nutritionist, has a PhD in child and adolescent health from State University of Campinas. She is associated professor in the Department of Nutrition and the graduate program in nutrition at the Federal University of Santa Catarina. She leads the research group Evidence-Based Nutrition for Clinical Practice. She was a visiting scientist in the Department of Clinical Care Medicine at Boston Children's Hospital in Harvard Medical School until 2015. She has experience in the area of nutritional status assessment, inflammation, and nutrition therapy, with a focus on the following topics that I will say now: development in food products, critical ill pediatric patients, pediatric chronic disease, and cardiovascular risk. Thank you very much, Yara. Please stay with us.
Thank you, Mayari. Thank you, Deborah. It's an honor to be here. So I thank the invitation. You know, I love the keto diet project. I think it's a wonderful project, and I would like to greet Professor Mackenzie Cervenka and Professor Patrícia Brocardo. It was fantastic learning a lot with you today. I don't know if I could argue in English. I have to confess I'm quite nervous, but I will try. I will try. And I am not a neuroscience researcher, so my comments here, Mayara, will be to improve the understanding of your thesis and your manuscript for the other readers. Okay.
Perfect.
Okay. First, I would use my chronometer to control the time. Okay, it's set. Your thesis have 3 manuscripts, and I don't know if the order that you put your manuscripts are the best order. I imagine that your systematic review was the manuscript that generate your main hypothesis and to study the cognition. So I liked when you, in your presentation, that was an amazing presentation, when you insert the systematic review on your background. I think it was fantastic. So you and Deborah can think about to include your systematic review in your background. As you cite your systematic review in your background on the thesis. So I think it will be really, really nice. Okay. As Patricia told you, you have to check all your abbreviations. It was very difficult to read sometimes. The fluidity of the text was really, really difficult. And I ask you to use the abbreviations only if it's needed. I think it's better to not to use all the abbreviations. You have space, no? So use wisely, please. Okay, let me see. I think the more important piece of your work is your main manuscript, the original one. I congratulate you for the publications of 2 articles in good journals. So I will go directly to the... Okay, let me see here. I have a lot of comments in the document, so I will send you after. Let me see. Oh, sorry for...
No, it's okay.
Before I think I would like to comment about the methodology of your study first. I think it will be better for me. One question. You, in materials and methods section, you wrote that your study is, let me see. It's a kind of confusing for me because I didn't understand in this session if your study is a secondary analysis of the keto diet, as you say.
Yeah, it's the big project. It's a part of the big project.
Okay, but it's not a secondary analysis. It's a part of the project.
Yeah, exactly.
Okay. When you calculate the sample size of your project?
We did with an article, but I already discussed with Deborah, and she also recommend, as we have the saturation over the time as the patient were sent, she suggests for us to take off the thesis But
Okay,
if you think it's better, we can try to put.
I have doubts. I think it's important for the reviewers to state, I know how much patience I need to have the power, but in the other hand, most of the studies have a small sample size. You cite a systematic review with 16, I believe, studies, and they have only 2,000 patients. So we can observe how all the studies are very small. Sorry.
Yeah.
But I think it's important, or at least you think about what was the effect size that you expected. It's important. And when you calculate the sample size, we think about this. You could answer me, how was the effect size that you expected for BDNF change?
Can you repeat, Professor, the effect size from the keto?
See, the BDNF is one of your main outcome, yes? How much do you expected the change of BDNF along the...
From the baseline?
Yes.
As my expectation, as like what I have read and what I was expecting to reduce?
Yes, that you use for your sample size estimation.
At 20%? For the side effect?
So this is important. I don't know how much you expected, but it is very important for your discussion of your paper, because for you, 20% of the reduction is a significant effect size. So it's important you to not correlate, to discuss this, because sometimes we observed a significant increase or decrease, but it's not clinical relevant. So that's why I asked you for all your outcomes. It's important you to know how much do you expect it to see the difference, and after discuss in your manuscript if this difference are or not clinically significant. So I suggest that you include these observations in the discussion of your manuscript. I think it's important and will improve the manuscript. Okay, let me see if I have. Okay. When you regarding the cognitive function, you use as a score, yes?
Yeah, with the total amount in seconds, and is as fast as the patient can finish. That's the measure. Okay.
And you, in your manuscript, you show us along the time. The variation. There is a cutoff for this evaluation.
No, like the patient actually. Sometimes patients say, I cannot finish. I'm very tired, or I just had a seizure. I cannot do the test now. So we also compare the first time and how fast he can finish. We have only 2 patients that we try to apply, and then they just could not finish the test. So then we just do not follow this patient in the cognitive assessment, but they drop the diet.
Okay, but the test, there is a cutoff to say it's a good or not good cognition?
No, what we have is the patient who doesn't have seizures. They they will finish the test faster. We have just a comparison from patient with or without epilepsy, or in other fields also, like other disease.
Okay. And
You think it
regarding
would be interesting to put a comparison from patients without epilepsy?
No. I just would like sometimes when you have tests and we use scores, we can set a cutoff. Sometimes there is a cutoff in the literature, or we can set a cutoff just to see if the patients, and then we can categorize the patients, just to see if patients change the categorization. For example, in quality of life, the score was from 0 to 100. Yes. And in the beginning of your study, the mean was 50 something. And in week 4, 78. I don't remember from the top of my head.
Yeah, that's it.
Okay. Perhaps 70 could be I don't know, a cutoff. So you can categorize your patients in good quality of life or not good quality of life, and see how many of the patients change the category.
Perfect.
So that was my the line of my thoughts. If you have as a descriptive analysis, perhaps you can see how many patients change the categories. Perhaps for the clinicians of the clinical practice aspects of your work could be an interesting point to see how they change from the categories. Of course, I'm not a neuroscientist. I'm just thinking how the clinician will understand and apply your results. Nebra, you would like to speak?
No, I just say that they have a cutoff. Trail making test for the one, and they have one to brain damage or no.
Okay, so you can include in the methodology and perhaps analyze this. Okay. Let me see. You wrote that your analysis, the statistical analysis, was adjusted by drug and age. Yes?
Can you repeat? By?
Drug and age. I don't know.
Yeah.
But how you adjusted for drugs?
We
number of type of the drugs?
The number, the quantity of anti-seizure medication in milligrams.
Okay. I think it's very important that you state this on your paper.
Perfect.
Okay. And in your paper regarding the background, I think it's very important that you state how was your hypothesis. It's not clear in the background what is or what are your hypotheses. So I think you have to highlight this. It's important for the reviewer. I expect that you send and have this paper accepted, but I'm just making some suggestions to better understand. And you have a lot of table and figures in your manuscript. I think it's 13, 12 tables.
Because each article, right, have its own.
But no, I'm saying just on your manuscript one, the original
okay.
one. And you present the results as a median and by patients, yes, like a case series. I love the idea of a case series, but it's a lot of tables. So I suggest that you choose one, or the median, or the like a case series, and the other you could write in the text or use as a supplementary material.
Perfect.
It's a lot. It's many data, so sometimes it's kind of confusion to understand and all your results. So I suggest that you choose one or the other set of the tables. But it's very nice. All the tables are very, very nice. Regarding the intake, as I am a nutritionist, I should ask you about the food intake. I think it's important that you describe the method that you use to record the 24 hours record. You follow
Step by
any
step.
method? Yes, so it's important that you wrote and reference this.
Okay.
Okay. And regarding the zero concentration of BDNF and NSA, I remember the time that I used to be at a bench and run a lot of ELISAs. I think it's important that you include in your manuscript how the serum was obtained, how you have storage. Yes, because I think this is important information about the quality of your sample. And sometimes proteins are very sensible, and they can change. And because you use ELISA, that it's receptor specific, if I remember. If you don't state that it was very carefully, it can be another bias for your result. So perhaps all the reviewer can ask, you have a lot of non-detectable amount of NSE or BDNF because it's below all because your sample size are degraded. So it's important you to state that you have a good quality control to run all your tests.
Perfect.
As you state this, you wrote some of these on your limitation of your study, yes? Okay. Let me see what I have to ask. I was very intrigued regarding the anthropometry and body composition. The patients lose weight during the time, but you don't know which component was changed, yes? Because you presented the percentile of fat, and lean mass.
Yeah.
And lean mass, the percentual of lean mass and fat didn't change over the time. But in kilograms, you try to analyze in kilograms because they lost weight. And I think it's important to know which compartment.
Yeah. Perfect. Actually, when we look to, can I answer, Professor, or do you want to finish?
No. It's a dialogue.
Yeah. So when we, in the master, when we look to anthropometric factors, we have separately women and men. So what we can say that in this sample size, if we get separately amounts, we would have just like so few patients to try to run the statistic. So we choose to put all together for analysis. So what happened actually is that we cannot see a significant one decrease, but if you look in the fat-free mass, we start with 68 and we finish with 58.
Yes.
So it was not significantly because women did not lose fat-free mass, but the men, they lose more than women. So I think probably is because of this, the men, they have higher amount of body composition from fat-free mass, and the diet is more impactful to them when you look to the fat-free mass compared to women's. But as we are all together, the women, they just keep higher in the score from the loose. So I think that's why we haven't seen the significant statistics, but for sure was more from the fat-free mass than from the fat mass.
So I think it's very important. Perhaps you can describe as in kilogram, in kg, not as a percentual. And what do you explain the reduction of the fat-free mass?
Because the ketogenic diet in the first month and during the keto, we provoke these similar states to fasting. So the body is using all the type of energy he can to try to survive. So he will take from fats and also from other storage. So the muscle mass can also decrease. But what I really think is happening is that in certain stage of the diet, patient, they just get a little bit tired of eating so many fats and not carbs that they start to do a little restriction, caloric restriction. So if I have a man who have a weight from 90 kilograms and he starts to do a 2,000 calories or 2,500 calories, he probably will lose fat-free mass. So at certain stage of the diet, I really think that some patients, they cannot achieve the correct amount of the calories, even we doing the meal plan, we talk to them, you need to eat more. I think it's naturally for them being so satisfied and they just say, I cannot eat anymore and I'm just good like this. I think this is actually really, really happened to them.
Okay, I think it's very important to state, and as I like to study sarcopenia, I'm thinking, wow, imagine another adverse effect. So perhaps we should think about sarcopenia in these patients. I don't know, but it's another outcome to explore in the future. And regarding the Patricia comment about the cardiovascular outcomes, I think it's very important. And I believe you can use Gabriela Neves' paper. If I recorded, she studied about this. So, and show the safety of the keto diet. I think it's very important that you include this on your discussion.
Very nice. Yeah.
As I was in so many defenses and committees, I know the study and the papers. Okay, let me see. I have just a couple of the questions. In your discussion, I think perhaps if you choose to describe the patients or the median, it will be easier to focus and profound and to improve the discussion. Perhaps I think sometimes it needs more, I don't know how to say, aprofundamento.
Going deeper.
Yes, go deeper. Yes, thank you, Mayara. Your discussion.
Perfect.
But it's a curiosity. When you show the symptoms of depression and anxiety, and the pre-diet, I think it's not. I think it's quality of life here. I think it's quality of life.
Yeah.
Yes. So you point it was 54. This score is similar in other studies with patients with epilepsy.
Drummer, he already did a study with Collie, and we saw we are almost 14 points, 14, right? 14 points above him. So he looked for quality of life in epilepsy also. So this sample size is a little bit higher than the usual patients with epilepsy that we see in other studies. A little bit, not too much.
But this number is not on your discussion. So I think it's very important that you compare your population. Yes, in the pre-diet and after the pre-diet. So you can, I think it's important to review the importance of your protocol.
Perfect.
The patients are different. And the discussions, I think the discussion sessions, it's very important not only to discuss the statistical differences, but to compare to other studies. As your study, it's very small, only 11 patients. Yeah. I think comparing, I think it will be review, of course, and to highlight the importance of your work. Okay, let me see if I have. Okay, and I think it's one of the last. The adhesion of your protocol, it's very nice. Professor Mackenzie said it's many patients and most of the patients adhere the diet for more than 24 weeks. So I believe it's very important that you highlight the protocol. What do you have? What is different in your protocol to the patients maintaining in the diet? And do you give the patients some orientation regarding the type of the fats they should intake?
As our patients don't have many times they don't have a good financial support, we stay very open to what they can achieve. But in our list of ingredients, we put the most common here in Brazil and not mais caros, os mais acessíveis, né? The more accessible ones.
Okay.
So we put suggestions.
But I'm asking regarding the types. If saturate, polyinsaturate, mono.
No, we don't do that.
Okay. Perhaps in the future it's important to orientate, advise the patients. I'm thinking about the adverse effects of the the
The
keto
keto.
diet, né? Yes, when you're thinking about cardiovascular disease, so it's important they to know and choose wisely.
Perfect.
Okay, I think it is the other things. I don't. I think it was covered. Finally, I would like to greet you. It is a wonderful project, and I would like to thank you for being here, and I apologize for my English, but I try here. So thank you so much, Mayara and Deborah.
Thank you, Professor.
Thank you very much, Yara. I forgot to say when Patricia talks about the comorbidity that, of course, we have a diet that it's not a good idea for a cardiovascular person, I think so, but it's like a cost benefit. So if you reduce the crisis, you can use some medicine to control like cholesterol, other things. This is like you put in a balance and you think, oh, this is better for the patient. We can have a good control with some medicine. So we choose the diet. So this is very important. We have some diseases that are criteria for not do the diet, like pancreatitis and other kinds of disease. But the cardiovascular one are not exclusion criteria, for the patients. I believe that these questions that Yara say about the composition of the lipids, it's a very, tricky one. Is very difficult. It's so we have 70%, 80% of fat. You can choose everything. You can put all olive oil, all the very good, but these costs are very high to have this kind of diet. So our patients, it's very difficult to do that. I think so, but also we have saturated one. You can do that. It's a lot of fat to do this choice, but it's important to study. I think they have some study about it in Brazil, including one with children's, but it's a very good idea for a discussion, for other study, the quality of the fat of the diet. So thank you very much. Now we have this moment when we go to another room. The Mayara stay here a little bit alone at the moment. But before we do that, I like to ask if we have here at the room Professor Katia and Professor Julia that are from the project. If they like to say something about the questions, please. I invite you to open your camera and talk to us, because we know this work are made together with all of us. It's not me or just also Mayara. So if Julia and Katia like to say something before, it's okay.
No. About the questions, about the defenses and the answers, I'm okay with that. I just want to I'm very happy that Mackenzie is with us another time, and I thank Professor Yara, Professor Patricia about their questions and about this. Oh my God, my camera. Are you listening? My voice?
Yes.
Yes, okay.
Yes.
My camera is out. Okay, and I want to, this is a Herculanic project, because for us it's very difficult to do this kind of study in Brazil. We have a financial, thank God, and there's a huge team behind this data. Maira is one of them. I thank Maira for all your efforts to be in the project and make contact with the patients. And Maira was very dedicated to the project, and this is very important. And we have this data because of Maira also, and Professor Katia that initiate all this project. Without Professor Katia, we are not here today. So I want to thank a lot, Katia. I'm very proud of our data and our project. We know that there is a lot of, how can I say this, bias that we have to I don't know how can I say this in English, transport. But what, Deborah?
I think about passing by. I don't know.
Yeah, passing by some bias and improve our study, but I'm very proud of it, and I thank Maira for being with us during all these years, and Professor Katia as well, and Deborah about this partnership that never ends, I hope. Thank you.
Yeah, let me say just a few words here since I was mentioned. Is just to say that really we're so honored to be part of this thesis defense and this group, and we have so important scientists and researchers here with us today. Mackenzie, Patricia, Yara, thank you so much for teaching us so much today and for your time, your valuable time. And just to say that this is the result of a huge teamwork that started in 2017. The professors Deborah, Leticia, and Julia, Mayara have been with us since the beginning. We are the pioneers here. And my only concern is that Mayara cannot leave us. Please, Mayara, don't leave us, okay?
Very important.
Yeah. Thank you so much. Bye-bye.
Thank you, Professor.
You. Now I will try to make some other room that when you accept to go to this room, we go out from here so we can talk a little bit without Mayara about his grade and everything. And then we come back here before to finish this session, okay? So I will create now. Okay. Did you receive my invite yet? I think I don't put me on the room. Tá todo mundo lá, menos eu. Deixa eu ver.
Vai dar tudo certo.
Gente, eu não me convidei? Oh, peraí. Ah, tá aqui. Sala de apoio. Entrar. Tá aí, Maira?
Oi. Estamos de volta.
E não. Te pediu para entrar. Okay. So now I will pass to the reading of the document of Maira defense. 1 second. Okay. Okay. On August 26, 2004, the doctoral thesis defense of student Maira Cristina de Lima took place in the nutrition graduate program in an open section chaired and recorded by the advisor, Professor Débora Curli-Higir-Vensky. The thesis is titled The Effect of a Ketogenic Diet on Several Levels of BDNF, NSA, and Cognition in Adults with Pharmacoresistant Epilepsy, a quasi-experimental study. According to the regulations of the graduate program in nutrition, the thesis defense consists of 2 stages. The first involving the oral presentation of the study conducted, and the second involves the defending against the examination by the members of the examining committee. The chair of the examining committee initiated the proceedings with the formal opening at 8:30 via video conference with the reading of these informations, signing by the coordination of the program. Next, the floor was given to the doctoral candidate who presented their work for 41 minutes in an open section. After the presentation, the floor was given to the members of the examining committee for the questions of the doctoral candidate who responded each examiner. Upon completion of this phase, any suggestion for necessary change to the text were recorded in the document that was sent to Maira. Based on the evaluation by the members of the examining committee, the candidate Maira Cristina de Lima was considered approved. So we have some modifications to do. You have 90 days for submission of the final version. Okay. Approval will be valid provided that the conditions required by the members of the examining committee are met with the submission of the final version of the thesis endorsed by the advisor. The examining committee highlights the quality of the oral presentation, the importance of the study being the first outpatient clinic for adults in Brazil, and the originality of the outcomes. Correction and suggestions for modifications will be sent to the student. So, if Maira, you agree with this document, you need to assign before this moment. So, congratulations.
Thank you very much. I really appreciate all of you that accept our invite to be here. It's a very honor to be able to talk science with you and to also to receive all your comments and suggestions. And Deborah was almost, I joke, almost a marriage, because 7 years together, I learned so much. I really thank you for all your patience and all your love for neuroscience. You really changed my career. Thank you so much. And I appreciate all the professors that been also here with us, Julia, Katia, and Professor Leticia that is not here. And thank you so much. And a special thank you, Mackenzie, for being here with us and for inspiring our project also. It was so great to see you in person and to be able to talk about our results with you again. So thank you very much. Professor Patricia, also I appreciate all your comments and about BDNF, and very original. We bring very improvement in our article. And Professor Yara, I have so many great memories because you were my professor in the graduated moment. You was with me in the master degree, and you are now. So thank you very much for accepting this comment also. Thank you very much. I'm very glad that I passed, and I hope that I can also take this with me, because sometimes we lose a little bit of hope when we see nutrition go into aesthetics condition and only try to do not so great things with people. And this project gives me back the hope that we can actually change the life of the patient with nutrition. So I really appreciate all of it. Thank you very much.
Congratulations, Maira. This is not a divorce.
Yeah, no.
We worked together for a long time, I think. So I also like to say, like Professor Katia and Julia, that I have so proud of this work, and Maira especially, who worked with us at the first moment that we start. So when Katia asked to us, so let's go to do that, Maira was there and start all the project with us. So she have a lot of knowledge to know about it, and say and talk to you even than me. She have this direct contact with the patients that I have just a little bit when I do some part of the work. So Maira have this all day contact. So they have a lot of property to say, to talk about this work. And for me, it's a very pleasure to have you like with a student. We have a lot of moments, and I just like to say thank you. It's very honor to me to advise you. You advise me many times also. I think it's a way that we have some, it's going back.
Actually, yeah.
Yeah. So thank you very much for the paciência, né? And also, Maira is my first doctor. I never forget. It's important to have our first student. We never forget it, but for me, it's important that this student was Maira. So thank you very much. For me, it was a pleasure. And it's not a divorce. You have a lot of work to do, and we need you to work with us. I think before this moment, we have many plans. Maira also have in life, in other things that he sometimes putting back because of us, of our work. So thank you very much for that too. Thank you, Mackenzie. Thank you, Patricia. Thank you, Yara. I'm very honored to have you here. I think this is the best one that we have on this topic. Thank you very much. So now I will declare this moment finished. And if you like to say something, stay away, no problem. Thank you very much.
Congrats, Deborah, the first one.
Yeah.
Yeah. Congratulations to you both, Maira, Deborah. And also just thank you again for the opportunity to come and see you and everything, all of the work that you've accomplished in Brazil. I think that was just absolutely amazing, and for giving me the opportunity to be a part of this as well.
Thank you very much. Now, Maira, you sent to you some documents and information for all of you from the next steps to the
I will send the participation. Yeah, the certification of that you are being here together, I will also be sending. And just to reinforce that the signature from the ATA, and I will send to Mackenzie also the translation. So that's it. Thank you very much again. I wish you a great week for all of you, and hope to see you soon.
Thank you. Thank you very much.
Bye-bye.
Thank you.
Parabéns.
Obrigada, Prof. Bye-bye, Mackenzie. See you. Beijo, Prof. Nos